All right, quick scan of my room. Wow, that's you in the mirror. Yeah, almost better picture than what it is. All right, and back to my subject. All right, hello, and once again, my name's Tom Hudson. I'm here for assessment number 2 of the assignments. Today we're assessing the chest, specifically cardiac, lungs, and abdomen. I have my lovely subject here again, my wife Becky, helping me out with this. And of course, once again, proven I have a consenting adult.
Yes.
I have a consenting adult. So we're going to start off, of course, looking at the chest, looking at the symmetry. Always like to ask, coming from a trauma background, a paramedic background, always looking for symmetry, especially with respiration. So I always like to ask my patient, take a full deep breath, assess. For me, looking for nice full movement, expansion of the lungs, paradoxical movement, a bad thing, flail segments, broken ribs, that kind of stuff. This is not a trauma assessment, but those are the type of things I'm looking for. And I'm seeing that all. I'm liking what I see. I'm going to have my patient turn just a little bit towards me and have her do the same thing here from the back. Another nice full breath, good symmetry, good air movement, and I'm going to ask her to say the words 99, just slip, roll forward slightly, and say 99.
99.
99.
99. 99. 99.
And feeling good frematus throughout that chest. Now just a set of percussions. And as I percuss here, I can feel the hollowness of the chest. As I move down, I start to hear a little bit more solid sound as I move over the kidneys. We can also use this to determine our movement of our diaphragm, and the way we would do that is ask our patient to take a full deep breath and hold it. And we would mark the position where we lose that. Go ahead and breathe for me. So we go ahead and mark that position. And now I would ask my patient to exhale and hold it. Exhale, all your air out. Hold it. And we would note where that sound is, put a line, take a measurement. And usually in centimeters, that'll give us the amount of movement of our diaphragm. Now that I've percussed the back, I'm going to go ahead, take a quick listen here to my lung fields in the back. I always like to start low, just breathe for me. Start low, working my way up. And comparing side to side, moving up through our fields. Another breath. Now listening over the scapula. I just like to listen at the trachea. Good air movement through there, no stridor. Go ahead and hold your arms up for me. There again, comparing side to side. Bring your arms down. So lung sounds are clear to auscultation, not hearing any adventitious lung sounds, not hearing any rubs, nothing out of the ordinary. Can go ahead and ask my patient to lie down at this point. So at this point, we're going to start assessing the cardiac portion of the chest. always like to mention it, especially coming from that trauma background again. When I'm dealing with a trauma patient, I always like to palpate, auscultate, twice. That way, if there's something loose or something that's knocked loose by my assessment, I pick up on it listening that second set of lung sounds. Just a good habit to get into, especially when you're hands-on with your patient. So for our lung sounds, we're going to start at the right sternal border, second intercostal space, right off the angle of this there. I am listening for the aortic valve here. I'm going to come over to the second intercostal space, left sternal margin. We are listening for the pulmonic. We go down to third intercostal space, left sternal border. This is Erb's flow. Fourth intercostal space, we are listening for the tricuspid valve. And fourth to fifth intercostal space, midclavicular line, just below the nipple there, and we are listening for the mitral valve right now. Hearing a solid lub dub, no S3, no S4, not hearing any murmurs. As I look at the chest, I'm looking for heaves, rises, pulsations, masses. Not seeing any of that with this patient. As I go through my pulse checks, starting with the temporal, and before I push on carotids, I usually like to listen to see if there's any bruit. No bruit noted, so we'll go ahead and assess our cardiacs. We're also going to check an apical pulse right at the point of maximum intensity. Fifth intercostal space, midclavicular line. Should be a very small area there where it's right up against the chest there as far as the heart's concerned. We'll check our brachials. Feeling good, strong pulses, no threadiness, they're not bounding. I like to, when my patient's on a cardiac monitor, I'm comparing these pulses with what I'm seeing on